It really is quite an honor to be introducing Dr. Mangat tonight. Actually, I had a wonderful radio interview with him earlier, and we had a great discussion about his work with the complex COVID patients, particularly those with complications such as neurologic complications, both of the illness and now with the vaccine. And I was really pleased to be able to talk with him for an hour. My show is on AmericaOutloud.com platform, and I am a Team Nation guest host for Malcolm once a week with about 2 hours on the platform, sometimes more, sometimes quite a lot more. And really has been wonderful to introduce some of our top COVID experts and have a good lengthy dialogue with them. Dr. Mangat graduated from the medical school of the Royal College of Surgeons in Dublin, Ireland. He trained at the Teaching Hospital of Trinity College in Dublin and Oxford affiliated hospitals outside of London in family practice and ophthalmology before completing an internal medicine residency at Mercy Catholic Medical Center, Philadelphia, and ophthalmology at the University of South Florida. He was an attending physician at the Veterans Administration Medical Center in Washington, D.C., which is an affiliate teaching hospital of Georgetown. And he also has been involved in teaching nurse practitioner students. He is teaching biomedical engineering undergraduates at the University of Maryland and is an assistant professor at Howard University College of Medicine. In the clinical realm, Dr. Mangat's interests include complex manifestations of conditions that include diabetes, retinal problems, sleep disorders, Lyme disease, including neurologic Lyme disease, viral-induced encephalitis, and now COVID. His work on COVID treatments includes an integral involvement in Maryland's antibody infusion program. And as an innovator and leader in COVID-19 early treatment, he has personally treated over 200 high-risk COVID patients early in the home setting and has taught over 600 physicians the successful multi-drug sequenced early treatment approaches that many of us have been using that have kept patients out of the hospital and has dramatically reduced the risk of dying from COVID. In other pursuits, Dr. Mangat holds 4 medical-related patents. He's on the managing board of an accountable care organization and interacts with healthcare policymakers from around the world. He volunteers to increase voter registration efforts among minority communities in the Montgomery County, Maryland area, and he's fluent in 4 languages. He is also active in the religious community and wrote the lead prayer given on Martin Luther King Day in 2006 at the Washington, D.C. Interfaith Convention. It's my privilege to welcome Dr. Mangat to our program tonight, and I know all of you are going to learn a great deal about some of the complications of COVID, complications of the vaccine, and COVID long hauler syndrome and treatment options. Thank you for joining us, Dr. Mangat.
Thank you very much for such a wonderful introduction. It's such an honor to be here, and more especially as my mentor and the person who taught me the most, Jim Rousey, I know is in the audience. So it's just a great honor to have your teacher listen to you. I'm sure he'll be inputting his valuable insights as he's done over the years to me. So let's just get an idea, where's everybody from? I know we're all from North America, but do we have any guests from outside? We could tell in the chat where we're from so we get an idea where we're coming. I mean, I have my true friend Raymond too, who just come back from ASNRS meeting where he's going to saw a lot of COVID stuff, and he presented some of the stuff that what we've done with Lyme. We've got Western Canada, we've got Gaithersburg, Maryland, we've got Las Vegas. That's terrific. Okay, I'm sure more will join. Delaware too. We've got quite the collection. Also DC. Okay. Let me just shrink. Let me try and get my screen if I can get this right, and we'll see. We'll see what else. Frederick, Maryland. That's great. I'm going to start with one of my favorite quotes. There's nothing to fear but fear itself. And this was said by FDR in his inaugural address in 1933. And I think this is very relevant because over the last year, we've seen people in fear of this virus, and it's caused havoc in people's lives. People lost lives, lost dear ones. Of course, it's disrupted economies. So let's talk about a few things. In figuring out how to treat something, we could understand the disease. And I think that's been a major issue here. We've got to know the anatomy, the physiology, the pharmacology of the body. And we could understand the mechanism of action of the disease. And this slide is a slide of Francis Crick and of course Watson. If we look at the double helix, when they first discovered the double helix, it's a great story by Watson and Crick. They talk about how they did it, and they actually built models. That's all they did here. If we look here carefully, and we read the book by them, Double Helix, it talks about how they got the images from King's College, Wilkins at King's College, and Linus Pauling out of California, and fitted the model to do that. And they stood on the shoulder of giants, a phrase used by Isaac Newton, and really is just putting all the data together and figuring out how to move forward. And the other important principle, which I like to quote, is the peak-to-peak principle. This was essentially taught by Dr. Schuller from the West Coast, the famous Schuller, the evangelist. And essentially, he said, you don't look or make decisions in a valley. You've got to get to a peak, then look at the next peak to make a decision and to figure out how to go there. Unfortunately, we've been too much in the valley of COVID. We've got to get out, figure out what works, and move to the next mode of treatment. So that's some of the things I like to say on just core principles. Next thing, a lot of us went to med school, and med school you get taught core anatomy, and all my classmates will tell you we were grilled for 2 years anatomy, and we had to know it backwards. And of course, the other elements of physiology and pharmacology, which are important in the practice of medicine. So we've got to go back and try and understand what these ACE2 receptors are, because they're not emphasized in training. They're not emphasized where they are. So if we look at the ACE2 receptors, they're everywhere in the body. They're in the alveoli, and when they're activated, as we've seen COVID, we get dyspnea. It causes inflammation, it causes pulmonary embolism. They're in the olfactory neuroepithelium, so right up on the tip of your nose. They're ACE2 receptors, and that's a pathway that the COVID gets into the brain. And that's a reason why people get these intense headaches. They lost their smell of taste. Lost smell first, then taste. And I'm going to ask Dr. Raymond too, he's on this, I see, to talk about it, because he just came back from the national meeting, neuroradiology meeting. There's a lot of talk about COVID, and we've had this discussion of how that transcends to different systems in the brain. There are 15 systems in the brain, and based on that, we can get an idea what's happening when we do MRIs. Next thing is to understand the physiology. We all know about ACE2 enzymes. And if we go back to core physiology, when we activate the ACE2 enzymes, we release bradykinins. And what does bradykinins do? Well, they increase cell permeability. That's why we see, lots of fluid in the lungs. That's why in the olfactory bulb, there's fluid around there. You lose your sense of smell. And the important thing is to understand how the body mops up this fluid. And the body is a very smart thing. It secretes hyaluronic acid. Hyaluronic acid, as my students tell me, the affinity for mopping up water is 100 times of anything else. So that's how it picks up the excess fluids. And what we're going to be careful of is what I call bulls in china shops. And as you know, that expression is very explicit. When we put people on ventilators, we've got to be careful we don't put the wrong settings so we destroy the alveoli and make things worse. So that's very important to understand on the physiology side. Then on the pharmacology, we've got to understand we deal with drugs that can prone you to picking up COVID. I mean, we have ACE2 blockers, R blockers, and ibuprofen, but they all upregulate ACE2 expression. So I tell my patients, avoid ibuprofen for fevers. And much to the contrary opinion of my cardiologist, I tell patients these are the options you can have on your ACE blocker. Or if you're in a COVID-rich environment, I'd advise you a different way of managing your blood pressure. But that obviously will always be a debate. Now, something else which is very important is understanding the evidence. And there was a great study, and I think came out of one of the great centers, which showed that if we look at the alveolar lavage of all the COVID patients, we saw some very interesting stuff. And we saw that the bronchial alveolar lavages showed evidence of upregulation of hyaluronate synthetase and downregulation of hyaluronidase. In other words, it caused hyaluronic acid to build up. Now, what is hyaluronic acid? I mean, I got trained in ophthalmology, and we use this product to put in the anterior chamber when we do cataract operations. It's a viscous, clear stuff, which it's not easy. It's very viscous, like gel. So you got to remember, when this is created, we are going to have problems. And if we look at our data, we have the highest morbidity rate in the world with COVID. And why is that? Well, we have an abundance of everything here, including ventilators. Okay, next thing I want to talk about is something relatively new. It's pathways. And this is an important pathway to understand. It's called the JAK-STAT signaling. We'll talk about COVID in a second and the pathways it goes through. But we've got to understand that COVID in itself creates a cytokine storm. And how does it do that? Well, it uses a particular pathway called the JAK-STAT pathway, which signals the body to create a hypersensitivity reaction or a cytokine storm. And there's certain drugs that can block this or prevent the signaling more correctly. And they're easily available. You've got famotidine available in every pharmacy in the globe. Now, Eli Lilly is trying to push its rather expensive baricitinib, but famotidine works as well. And there is evidence that Apoquel, it's an antihistamine used for dogs, also has a JAK signaling pathway blocker. So these are some key pathways. So if you look at this diagram, it shows you how the JAK2 blocks the release of the cytokine. So these are just core things that we need to understand if we're going to treat this condition. Okay, let's talk about coronaviruses, not COVID-19, coronaviruses. And I'm going to differentiate this. Coronaviruses were essentially discovered in 1964 by June Almeida. And it's called a coronavirus because of its hallmark characteristic crown appearance. And they've been around for years and years and years. They live in the back of the nose, the back of the throat. And that gives you an idea of how a first path of intervention. Rinse your nose, rinse your gargles so you decrease your viral load. Secondly, they've shown, and there's some good papers, that all coronaviruses immobilize the lung T cell. Keyword, immobilize. Immobilize the lung T cell response. So it puts you at risk of atypical infections, atypical pneumonias. I've seen mycoplasma, I've seen viral. Fungi infections. In India, mucormycosis is rampant. Until you see one, I was lucky enough to see one in Tampa. We saw a case, and really it's horrific because it encroaches into your nose, into your brain, and it's a horrible ending. Other important thing is COVID habitat. You've got to realize that COVID sits on facial hair and ventilation systems. I mean, I'm a Sikh and I should wear a turban and beard, but I elected to trim my beard after I got COVID because I realized it was sitting in the facial hair. And that's important to realize, especially to our brethren who are more orthodox, whether it be Sikhs, Muslims, or Jews. You've got to tell them, if you're to keep your beards, please wash them, especially if you're in a COVID-rich environment. And, you know, the evidence that initially came out of Bergamo, Italy, showed that COVID adheres to particulate matter. And this was later confirmed by Harvard when they looked at the fine particulate matter and COVID studied in the US. And they correlated higher prevalence of COVID in more polluted cities. I mean, that's a reason why the tiger in the Bronx Zoo in New York caught COVID, because there was such an amount of COVID in the air. So, you know, I advise all my bearded brethren, whether you're in Delhi or Detroit, in polluted areas, please wash your beard, because you may not realize you just walking outside, it will adhere to your facial hair. Okay, let's talk about COVID and COVID-19. This is very different from the coronaviruses of 1964. And I'm just going to use the words of Luc Montagnier, 2008 Nobel Prize winner. He analyzed this very carefully, and he showed that COVID-19 has a lot of gene variations, which include genes from HIV-1, HIV-2, and SIV. And COVID-19 is 1,000 times more, has 1,000 times more affinity to the ACE2 receptor than the original coronavirus. And the Indian variant is 200 times more potent than the original COVID-19. And I think Tasuku Honjo, the 2018 Nobel Prize winner, he said openly, so this is not an actual virus. I'll put my honor and I'll give back my Nobel Prize if I'm proven wrong. And he said that publicly. So we've got to be aware of what we're dealing with. We're dealing with a messenger RNA, which has a lot of variants of things which we are suspicious of. Now, this is a key slide. I want to spend time going over this. And this was initially presented by Peter McCullough on the Hill on the Senate hearing. And I want to go through it so that everybody understands this. I'm going to ask a few questions. And, you know, Jeremy, these are questions for non-physicians. So let's just look at this slide. And if we look on the y-axis, this is your mortality risk, the risk of dying. And if you look here, this is the days from initial date 0 of inhaling a COVID virus. And there are different phases of the disease. The initial week, 7, 10 days is a viral proliferation phase. You lose your fever, you have fever, sore throat, fatigue, body aches, and nasal stuffiness, and smell and taste begins to go. And this is the phase we want to treat. We want to get in here, prevent this progressing, because progression, as you see here, the mortality risk increases. More importantly, it goes through different phases as you understand the physiology. The bradykinin storm causes accumulation of bradykinins, increased permeability, and this is manifests with a cough, ground glass appearance on your CTs. And then, of course, as it exits, goes beyond the 10th day, we enter the cytokine phase, and we see the pneumonias. So cytokine pneumonias. Of course, when we're in the midst of the cytokine storm, the body is prone to creating thrombi, and we get deadly pulmonary emboli, we get DVTs, we get all sorts of heart complications. So the name of the game is treat here. So I'm going to open this up a little bit, and I want to ask you to ask some questions to non-physicians, because I want to make sure we understand this correctly. So let me ask a question. If we know a patient is in this phase here, when we're having thrombosis, and we only give antivirals at this phase, Do you think that's going to work? Any comments?
Yeah, go ahead and folks, if you like to weigh in, go ahead and type it in the chat room, and I'll read it. So not likely is an answer that we got. The antivirals will not work. Anyone else?
Okay, we've got a core concept here. Now, let me tell you the problem we're having. Peter, is Peter McCullough on there? Because Peter will validate this. We presented data to the FDA on some of the stuff we did, showing how effective early treatment was. And we got an inappropriate response, saying that they looked at a paper out of England, actually. It's quite amusing. They quoted a paper out of the Oxford group, which was funded by no other than Bill Gates, not the university. And that paper was looking at studies on treatment in this phase. So of course it's not going to work. So that's a stupid thing. But unfortunately, that quote from the FDA came out of the NIH. So we've got a problem. We've got people in charge of this misquoting or misunderstanding the disease. Okay, that's the first question. Next question here, cytokine storm. Another question here, if we have a patient in a cytokine storm here, and we give medications that affect viral proliferation, do you think that's going to work? Non-physicians only.
Yeah, I think most of we have a no. I think most of our attendees are physicians.
Okay, great.
Then
we'll move on fast. The
Yeah.
key issue here is if we look at the meta-analysis study that Mandeep Mehra did. Mandeep Mehra did a meta-analysis study on hydroxychloroquine. Hydroxychloroquine is okay in this phase, but meta-analysis of hospitalized patients, that was here. So that's the whole point. You've got to look at the studies that people are coming out with to understand where they are relative to the phase of disease. And if we've got bird brains going on CNN talking about that, all I can say, they're bird brains. So just be a little more competent. Likewise, on the bradykinin storm, we had our wonderful Dr. Jha, who wrote a New York Times Post op-ed, but he actually left a thumbprint on the bradykinin storm on hyaluronic acid, and it was clear from the thumbprint he left on the web that he didn't understand this phase. But we've had a lot of people talking about the disease, not understanding the disease. So that was the key objective in this slide, is to understand the disease, understand at what phase the disease is, then only then can you treat it. If you don't know that, you're just, pardon my language, you're just pissing in the wind. You're not going to get anywhere. Okay, next question. What I've done is essentially been seeing patients for the last year and treating COVID successfully. And to date, I've been very blessed that I've had one death, and that wasn't because I treated the guy. I found out my favorite patient landed up in the hospital in the ICU with COVID, and I wasn't happy, and that made me pick up the phone and talk to Peter McCullough after he testified in the Senate, because I wasn't happy the way he was being treated. But I learned a lot, because you learn from mistakes, learn from your own, and only a fool learns from his own mistakes. So you've got to look at this analytically and learn from other people's mistakes too. So what I call phase zero treatment. Phase zero treatment is to try and prevent the COVID virus getting into the lungs, creating problems that can lead to somebody dying. Pulmonary embolism, cytokine storm. And the most simple thing to do, most effective, is a nasal rinse. A nasal rinse gets to the back of the throat where the COVID normally sits. It gets rid of the virus, it decreases the viral load. Now, I've used other stuff too as well. I've used Befespi. And the reason why I use Befespi, it has glycopyrrolate in it. The glycopyrrolate essentially was used in intensive care unit 20 years ago to dry secretions. And it has a novel aerosphere, which gets into the alveoli and dries it up. The other option is to use ipratropium bromide. We said the wrong thing. Let's get back to that slide. Ipratropium bromide. Hypertrophium bromide, as you all know, dries up secretions. Now, the other interesting product was Alvesco or cyclosinide. The Koreans have used it effectively and shown it to be a antiviral against COVID. And also budesonide pulmicort is as effective. I don't have enough data to compare the two, but I've used both in my patients. I obviously prefer Alvesco. Okay, next slide. Okay. I want to go with this diagram since they're mostly physicians here. Okay, so just to summarize, this is the entire talk is 3 diagrams. We saw the first diagram. This is the second diagram. Understand nasal rinses decrease your viral load. Remember, the coronaviruses inhibit your pulmonary CD4 cells, and that's going to put you at risk of atypical viruses, atypical pneumonias, and also mucormycosis. Now, very interestingly, about 5 days ago, the FDA gave emergency use approval for sotrovimab, and that's a GSK product, a GSK monoclonal antibody, and that enhances the T cell function. What they claim, their claims, and we have to look at the hardcore facts, but I suspect the real reason is they got additional technology which increases the half-life so that it becomes more effective in treatment. We'll talk about that a little later. As I said, inhalers. I use glucoperolate, Befesbi, Breztri, and you can use ipratropium bromide. India has Ipravent, it's already available there. If we look on the steroid inhalers, obviously Alvesco and Pulmicort. Ciclohil is available in India. I mean, this is all globally available. So this basically lessens your risk of the stuff tracking into your lungs. I'm not going to say 0, but it lessens the risk and gives us time to work on other things. So those are key things to understand, and the rest is just verbiage. But take a picture of this slide. It says everything on the picture of the diagram. Okay, since we're dealing to mostly physicians, this is going to make life easier. This is a slide that shows you the intracellular COVID life cycle. We talked about phase 0, and essentially what I've done is I split this up. It's like the old joke, how do you eat an elephant? Well, you eat one piece at a time. So this is an elephant, and we've got to go through and understand what happens and why it works when. So we talked about the ACE2 receptor. When the spike protein adheres to the ACE2 here, that's what I call phase 1. We can treat it. We can treat it using monoclonal antibodies. These target these spike protein so that it decreases the viral load so it doesn't get into the ACE receptor. And of course, we've got a Regeneron, we've got the Eli Lilly product, and of course now we have the sotrovimab, which is the GSK product, which has Zenicor, which increases your half-life. So you get elevated pulmonary concentration and enhanced T cell function. Important point, go back to your day 1 physiology in medical school. Remember what we said? We said activation of the ACE enzyme causes increased permeability. And we have old-fashioned, I can pull this up here. We have old-fashioned Benadryl. Benadryl basically is going to act here, and it's going to decrease that fluid. Once the ACE receptor goes in, is opened up, this is mRNA. The mRNA goes in and multiplies, and it multiplies by various means, and eventually causes cytokine signaling here to release the cytokine storm. So that's what I want to go over. So what I'm going to do is go one phase at a time. So let's go on phase 1. Phase 1, as I said, is basically preventing the ACE receptor being activated. So we've seen, and we're still in the yellow phase. We want to be here. You can't use the monoclonal antibodies beyond day 10. So you want to be at this yellow phase, and you want to see the patient as soon as possible, you can't wait the weekend. I mean, they got to get the monoclonal antibody on board straight away. And we're blessed in Maryland to have a good system. We have our centers, infusion centers, open on weekends. So if somebody comes on a Friday on day 9, they are in on day 10 getting the monoclonal antibody. And I got to say, the state's done a good job. So unfortunately, I realized that this is funded by the federal government. And I talked to Dr. Chan recently, and she explained to me they're at the federal government gives them the monoclonal antibodies. I would like the new GSK antibodies as soon as possible, but that's up to the federal government to give the states, so we can do it. And I would encourage every person, every state here to utilize this, because it's there, it's sitting there for us to use, it's sitting there for patients to benefit. Important thing, little addendum, make sure you put some Benadryl. Benadryl will decrease your bradykinin storm, decrease the fluid accumulation, and they actually breathe better. I had a patient who was very surprised, and she had breathing problems. She said, I can breathe better with the Benadryl. And she knew about it because she's been on all sort of asthmatic drugs. Okay. Now, key thing to understand is it takes 2 to 6 days for the viral load to come to 0. So if you give the monoclonal antibody, you've got to make sure that you give it and watch and be very careful. And the reason I say that, if we give the monoclonal antibody around here, we are at risk. 2 to 6 days puts us in this bracket here. So you've got to be vigilant. And we'll discuss a case where vigilance paid off. So you've got to be vigilant and understand that the monoclonal antibodies in itself are not instantaneous. It takes time to come down to viral load to 0, and you can still get pulmonary emboli. You can still get complications. And as I said earlier on, the bradykinin storm is lessened by simple Benadryl, and we don't need any bulls in China shops. Okay, I think if everybody's most in the United States, we all know this. These are the indications for using monoclonal antibodies. Above 65, diabetics, BMI greater than 35, older than 55 with cardiovascular disease, hypertension, kids, if they particularly have a large sickle cell disease, congenital heart disease. These are indications. But the thing is, the key indication also is your oxygen saturation. So you can't sit on it. If somebody comes in, the oxygen saturation 94%, they're in day 5, you've got to move because it can take 2 to 6 days for the viral load to come down by itself. Okay, phase 2 intervention. Let's talk about this independently, because this is important to understand. What I call phase 2 intervention is after the spike proteins opened up and the mRNA is intracellularly. And we've got to go through this to understand this, because if we don't understand this, we're not going to understand how to treat it. So what happens is the messenger RNA gets into the cell, into the alveoli. The body tries to stop it by creating an endosome. And if we look at that, that's basically the body's mechanism of trying to stop it. It goes and replicates using the cellular machinery, and certain medications can prevent the replication, and we'll go into that. So what happens is, once that is occurring, it signals to the nucleus to initiate the cytokine signaling for the cytokine storm. And that's why I said call phase 3. But phase 2, we're going to talk about preventing the viral replication. And this can be done. Here, hydroxychloroquine, it works. It works to a degree, not all the time. That's important to understand. And it works to a degree because it basically prevents the endosome from breaking. If you have too many endosomes, what will happen? It will break. We have RNA polymerase inhibitors. Remdesivir is being marketed only in the hospitals. But we have a thing called lopinavir, ritonavir. good old-fashioned Kaletra, given early. It's a protease inhibitor. It prevents the replication of the drugs, of the virus. And that's important to know. That's what I've used from the very beginning. And it's a game saver. It actually helps people. Sometimes they're a little resistant because they think you're treating with AIDS. Once you explain to them, no, it's an AIDS drug, it's been useful in helping people getting over the symptoms, they're pretty open about it. So that's phase 2 intervention. Okay. This is our wonderful president, or former president. And a very interesting comment was made to me by Winston Hyde from Harvard. He said, more studies have been done after each tweet of President Trump. But there's a reason why I have this slide up here, because this is for the physicians, and I'm going to put the question out there. And there are actually 3 bonus points. This is the slide of the President Trump on his first presidential debate. What do you guys see? 2 bonus points I need. Open the floor to the physicians. What do you see on this slide? Irrespective of your political views, what do you see clinically?
I got an answer. Diaphoresis is one answer.
Good. What's the second one?
Yeah, anyone else?
You have to have the debate for the second one. I'm being a little partial.
Flushing, red.
Okay, same thing, diaphoresis, flushing red. Good.
And flushed and vasodilated.
Perfect. Flush, vasodilated, right. Exactly correct. So what does a viremia cause that? 101.
Anybody want to chime in on? Yes.
Okay.
Yes.
The second point, maybe you don't remember, but if we look at his behavior during that debate, I mean, we're physicians, forget the politics. He was a little different. And we all know when people have viremias and they have issues like that, they are going to be different. So do you think he had COVID at the time of the debate? Well, I'm not going to answer that because I actually made a call. When I saw it, I said, something's not right here. And I called my deep throat in the administration. He said, why are you asking? I said, this is what I saw. But they wouldn't answer, so I realized something wasn't right. Now, one other point. Clinicians again. This is a guy who is probably the best marketer of hydroxychloroquine in the world. Even Harvard recognizes that. Why did it not work for him? Any comments? Do you have anything, Jeremy?
My understanding is he was not given hydroxychloroquine in October when he got COVID. He was on it for 2 weeks in May and then taken off of it and was not at the time of COVID. The doctors did not want him to take it and recommended remdesivir and Regeneron.
I can't answer that. I don't know. But the reason I was asking that question is coming back to this point here. Endosome. If we go back to the physiology of COVID, it sits in air vents. If you're sitting in a White House full of COVID in the air vents, you can only have a certain amount of endosomes which will prevent, and eventually they will get released. So, I mean, hydroxychloroquine works. I'm not disputing it. And if you have a good immune system, it works perfectly. But if you're overloaded, we run into risk. So just bear that in mind. So that's a point I was trying to put across here. We know clinically we had COVID at the time of the debate. But the thing about it is, it's got to be a multi-drug therapy. You can't use just one thing. I don't know the answer. I'm just putting out there for people to think about it, because you got to think about the medications you use and why use it and when, and the pros and cons, like anything. So that's a summary of what I call phase 2 intervention. And maintaining the endosomes and using viral inhibitors to prevent the replication of the virus. So we're going to move on to what I call phase 3. Let's just look here. Here we go. We talked about that already. Oh, favipiravir. Favipiravir has been touted by a few people as a antiviral. I've had the fortune or misfortune of helping people in India, and the Indian experience is that favipiravir is actually very slow in that viral proliferation window. Remember, we have 7 days to get that virus load down. Otherwise, it would run into all sorts of complications. And favipiravir was not doing that in India. Okay, phase 3 intervention. And this is what I'm going to call the phase where we get the cytokine signaling. Medications that work, good old-fashioned Pepsid, baricitinib, these basically inhibit the JAK2 signaling and prevent the cytokine storm. And of course, phase 4, which what everybody knows is the cytokine storm, and we can use IL-6 blockers and the Eliquis and other molecules to prevent PEs. So we're going to go into a case now. So that just summarizes. This slide summarizes famotidine, how it works, and the other important point that I learned, and thanks to Peter McCullough and my case, was that the dosing of Solumedrol or prednisone is going to be sufficient to put the storm out. You can't stick to a protocol. You got to look at the patient, understand the patient, understand the needs of the patient, and give sufficient steroids to put out the cytokine storm. And this is very apt in this case here. I'm not sure if you guys can all see it, but this is a 46-year-old male in Delhi. And he had the AstraZeneca vaccine 4 weeks earlier. 2 weeks earlier, he started getting fevers, chills, and tested positive for COVID. On day 8, he became dyspneic, and he had a CT that confirmed COVID pneumonia. I got a call. I'm on day 20 now. Doctor, can you help us out? Give us a second opinion. What can you do here? And by that time, he had received ECMO. I can't get ECMO with my patients here. IV antibiotics, antifungals, remdesivir, tocilizumab, oxygen saturation on 15 liters was 90%. He was in the prone position. His D-dimer there was 563. Normal is less than 234. And this is a chest x-ray that came on my phone. Okay, I want some help. Guys, what do you see there and what would you do next since we have all the physicians on board? Any comments? Do we have anything in the chat? Jeremy, do we see anything there in the chat?
Sorry, I had myself muted. Okay, steroids is one suggestion. IV Solumedrol. I'm not familiar with that one.
That's fine. That's steroids. Go ahead.
Okay. So pneumonia. Someone's saying, oh, they see pneumonia. Pneumomedistinum is another comment. Someone, I guess, sees anticoagulants as a suggestion coming in.
They're all great suggestions. Okay, great suggestions. Okay, what I did was I looked at the slide and I thought this, I thought this may be a raised hemidiaphragm. Old-fashioned medicine, raised hemidiaphragm, you gotta think PE. So what happened was, let's see where we are. We're day 20. That's why this diagram is pretty handy. So we are bang in the middle. Thrombosis, cytokine storm, bradykinin storm. So what I told them first of all is, I think he's got a PE, you got to repeat the D-dimer. And they did. It was 834. So he was developing pulmonary PE. So I said, I know it's not indicated to give remdesivir or tocilizumab again, but you've got to put the cytokine storm out. So I asked him to repeat it. I actually did what the guy suggested. I put him Solumedrol 60 milligrams Q6 hourly. Also, I asked them to give 40 milligrams IV famotidine BID and 50 milligrams of Benadryl QHS. Beautiful thing happened. His oxygen saturation increased to 95% sitting. He was in the prone position, but he could sit. his D-dimer dropped to 329. So we managed to pull him out of the cytokine storm. And also, he was anticoagulated. They put him on heparin. So he did well. My unfortunate problem was we had a pulmonologist who insisted on putting him on a ventilator as opposed to a CPAP, and he developed complications. He essentially developed a pneumothorax, which he could not survive. So you got to be careful. That's what I call China's, bulls in China shops. You can understand what's going on. I would have preferred him to be on a CPAP with a pressure of maximum 20 centimeters. The trouble is when you use ventilators, they got to 60, and you could be careful on that setting. If you don't get it right, you're going to complicate matters. Okay, next case. This is one of my own cases in Maryland. I have a 44-year-old male who presented after a Christmas family gathering. He's known type 1 diabetes for 39 years, BMI 36, sleep apnea, and he had ARDS in 2004. He presents to me 7 days after 7 days of a dry cough, sore throat for 3 days, diarrhea for 1-2 days, constant intense headache, and a new onset shortness of breath. His pulse oximetry was 95%. He had fever for 1 day, no chills. He had lost taste and smell for the 5 days previously. He had just had a COVID PCR done yesterday and the results were pending. Okay, question to the audience. What do you do next? Let's open it up.
What do you think, everyone? Ivermectin, budesonide, and aspirin is the first suggestion that came up.
Okay, that's fair enough.
Anyone else? Get a CT of the chest.
Okay, that's good. Good. Anything else?
Reduce viral load. So it says doxycycline, a monoclonal antibody, steroid Benadryl, 128 slice CT, Benadryl and Z-Pak, fluvoxamine.
These are all great suggestions. I like this. People are thinking.
Yeah. Famotidine also suggested. And vitamin D.
Okay, that's great. We got people involved. I like this. This is the objective of this talk.
Yep.
I wanted to get people to think, to get involved. Okay, this is what I did. Okay, essentially, all the suggestions were correct. I put him on Kaletra, the antiviral. I put him hydroxychloroquine. I gave him aspirin. I gave him Alvesco. I gave him Befesbi. And I put him on Benadryl. And I used clarithromycin because it covers atypicals. And I gave him a methyl dose pack. And I also got a 128 slice CT angio to rule out a PE. So those are things I did immediately before I had the COVID result back, because clinically he had COVID. I didn't want to wait another 24 hours to get the PCR back. I was treating him. I was going to be aggressive about it. Okay. Next day, I get the PCR result. I pick up the phone and I call up my guys at the infusion center in Baltimore. I said, look, this is a case is COVID positive. He's on day 9, and they were terrific. They got him in and they gave him an infusion. And he's a very obedient patient. He listened to the infusion center. He said, everything's okay. And they told him, you don't need to do anything. We'll see you in a week. I said to him, you need to come back to me. I need to make sure everything's okay. And so a few days went by and I hadn't seen him. So I've got my staff to call him up and said, look, what happened to Mr. AP? Where is he? Why is he not coming back? And he's meant to get a CT scan done, a 128 slice CT scan. And what happened was we called him. I said, what happened to your CT scan? Oh, I'll go the next day. So he went the next day and he was getting more short of breath. And this is a beautiful 128 slice CT done by Dr. Uppal. I'm sure she's the one who suggested the 128 slice CT scanner. If we look here, we see pulmonary emboli in the wall. It actually, you can see it go through, that's the dye, but that pulmonary emboli beginning to be formed. Now what do you do? Okay, guys.
Yeah.
The floor.
What do you got? What do you got, folks? What would you do? Anticoagulate is the first answer that came in.
What would you use? Great answer, but what do you anticoagulate with?
Yeah, low LMWH, Eliquis, Lovenox, Eliquis have been suggested a few more times.
Correct. That's good. Anything else? Okay, let's move on. Let's see what I did. I'll tell you what I did and what happened next. So, okay, right. Get back. Let's go back. So what happened was let's get to the right thing. Here we go. First of all, I suggested go to the hospital. He refused. And he refused because his sister was on a ventilator. He said, I don't want to go to the hospital. I want you to treat me. Well, you're kind of stuck. So what we did was we actually gave him, I'll find the slide. Here we go. What we did was we gave him Eliquis, 10 milligrams BID, put him famotidine, and this is where I was lucky. I actually have a lot of very complex Lyme patients. I give them IV antibiotics. So I got Optum to give him IV Solumedrol 60 milligrams BID and IV ceftriaxone 2 grams in those initial days because he was at risk of pneumonia. And he was, he had the monoclonal antibodies. They were bringing the viral load down, but we're running into complications. And, simple things, incentive spirometry, it helps. After 10 days, he still wasn't getting better. So I had to scratch my head again. And going back to the core concept that your immune system is not working properly, and he was still coughing off yellow phlegm, I added Valtrax 1 gram TID for 7 days. And within 24, 48 hours, he was a lot better. He actually developed a viral pneumonia, atypical viral pneumonia, secondary to his immune system defunct. 2 grams of ceftriaxone kills everything. Now, the nice thing about this case, Mr. AP returned to work in 3 weeks after initial COVID infection. His sister returned home 4 weeks later on oxygen. Remember, don't allow the bulls in the china shop if they're not needed. So this was a lesson learned to me. I had to respect his wishes. He wanted me to take care of that, and I did. And essentially, it goes into phase 4 intervention of what we did. We essentially gave the famotidine, as people suggested. We gave him Eliquis, as people suggest down here. So we could treat the pulmonary embolism, and we didn't need to go to use IL-6 blockers. You wouldn't go to hospital anyway. So it was a catch-22. You try your best, but if you can't do that, you have to respect the patient's wishes. And thankfully, we put him through the cytokine storm. The key thing about showing this patient was, 1, understand the complication of the monoclonal antibodies. It takes 2 to 6 days. 2, if you're stuck, the patient doesn't want to listen to you, you have to respect their wishes and do your best as a physician to pull them through, and it can be done. But it means a lot of hard work. You need to chase him up, make sure everything's done okay. Check his oxygen saturation every day. Talk to your IV infusion service and make sure that everything's been done correctly and be on top of it. But, we pulled him through. Okay, next question. We got another case. Okay, this just basically summarizes phase 4. You've got to anticipate complications, pulmonary emboli, anticipate atypical pneumonia, viral pneumonias, and anticipate atypical fungal infections. Okay, on the whole, this doesn't happen. On the whole, monoclonal antibodies are great. I have had high-risk patients on monoclonal antibodies combined with a multi-drug therapy, getting better in 3 days. I know people who don't qualify the monoclonal antibody, they get better, a little slower, but between 7 to 10 days. But essentially, they get better and they can be at home and they don't land up in the intensive care unit. And that's a benefit of doing early treatment. So the message, it doesn't matter what you use, whether you use ivermectin, whether you use an antiviral, have a plan of action and understand the risks and the complications and be ready for them as they arise. Because if you don't think about it, you're not going to know what to do when they arise. And that's the most important thing to do, is be ready for the complications as you go through. Okay, I got another interest. Okay, this is Optum. Optum is the company who does the home infusion service for me. Lynn Crummett is my person who, basically, if other people want to be need their services, they're a national company. So this is the detail that I'm sure making this available through Jeremy to anybody who needs it for their patients. And they've done a great job on a number of my cases. I mean, that was just one case. I have a number of cases where we treated people at home or treated people early because I couldn't get monoclonal antibodies. When we started off, I remember there was a case on day 7, and that time they were giving monoclonal antibodies on day 9, and I was seeing a COVID pneumonia. I just put him on IV infusions and treated his pneumonia before he got the monoclonal antibody because we had a 128 slice scanner in our backyards and we could pick it up early. And that made all the difference in the treatment. So this will be available to anybody who wants it later on. Okay, next case. This is an interesting case, close to my heart because one of my staff members. A 39-year-old takes her first Moderna shot. 24 hours later, she starts getting a dry cough, dyspnea, fever, intense headache, loss of smell and taste. And we get a rapid COVID test 48 hours later. It was equivocal, so we did a PCR, and that it would take 4 days to come. Oxygen saturation was oscillating 92 to 97%, so worry about a PE. Did a CT angio with a wonderful 128 slice scanner, didn't show anything. My partner started on cefalexin, dexamethasone. Pulmonary symptoms partially resolved, as well as some other taste and smell. So the patient came to see me. So, 2 weeks after the first Moderna shot, she noticed severe frontooccipital headaches. She's unable to watch TV with her 8-year-old. She says the sound is too loud. She can't read the numbers of those wretched lawyers and the TV ads, the ones they put the phone numbers to call them. She can't read it. She said, something's not right, doctor. I can't read those ads, especially on the shopping stuff I want to buy. And she gets dizzy on standing. Okay, 2 questions here. And this is going to be for neurologists, ophthalmologists, and ENT. Where is the lesion and what do you do next? Okay, let's open the floor up and see. Any volunteers?
Could it be a thrombosis in the vein of Galen?
Sure. What else could it be?
Someone else had typed in orthostatic. I'm not sure if that was in response to the eighth nerve is another suggestion.
Good. Very good. Who's that guy?
Optic chiasm, CHIASM, seventh cranial nerve.
Good. People got sharp people here. What else?
CVT is a suggestion.
I'm not sure. I'm not sure the acronym.
Yeah.
Okay, let me tell you what we did. This is a very interesting learning case. Okay, physical exam. We're clinicians, we're doctors. Examine the patient. You can do it on your video chat, on your telemedicine, And essentially, you can actually do a exam by asking them to putting your chin and getting the partners to be your hands and eyes, be your hands over the web. So, I mean, she was obviously in my office. So she came in and we examined her, and I examined her. And she had diplopia on looking to the right. Looking to the right and down and out to the right. She had weakness of the right buccinator and the right orbicularis muscle. And she had a positive Romberg sign. So what I did was I ordered a 3T MRI. And I specifically asked attention to details at the sella turcica, internal auditory canal, and the mastoid component of the facial nerve. Okay, who wants to come and explain to me why I ordered those specific things on to my neuroradiologist? My neuroradiologist can't answer. So Katuri, don't talk, or Raymond, you can't answer this, but you know the answer. You just presented at a national level conference. So anybody else want to volunteer, why 3T MRI, first of all? That's the most important thing.
What do you guys think? Give people a second to type something in.
Sure.
Higher resolution.
Correct, but why? That's a no-brainer, but why?
Anyone?
Okay, let me go.
Here we go. Cavernous sinus involvement. To look at that possibility. Higher signal to noise ratio. All right. Yeah, I'm not. Microthrombi.
They're all great answers.
Oh yeah, and someone wants to know. Suggests you include the importance of the contrast media.
There's a reason for it, and we'll see in a second. I don't want to give the game away just yet. We're on the right line. We got good people here. Okay, let's do the next slide. Okay, Dr. Couture, are you there? These are the slides you put the arrows on. You want to talk about it, or do I have to talk about it? I don't know if she's there or not.
Oh yeah, if you're there and you want to talk, just click the raise hand button and we can unmute you.
Oh, the other, if Dr. Couture is not there, Raymond too is there. I know, sorry, money on. Raymond, if Couture doesn't come on board, you want to talk about this because you know this stuff.
Yeah, okay. Dr. 2 has raised his hand, so we'll bring him on here.
The floor is yours. Go ahead and what you see and why.
Yeah, Dr. 2, welcome. You may have to click unmute on your side there. There you go.
Jeremy, can you hear me? Dr.
Yes, welcome.
Yeah, perfect.
I wasn't sure if Dr. Kathuri was on the line. I thought I heard some.
Well, he's not answering, but you're as good as Sudhir, and you've seen all this before, and maybe the time you can tell everybody what you saw at the National ARNS meeting about.
Okay. Good evening, everyone. This is Raymond too. I'm here in Washington, D.C. And this is the first time I'm seeing these images from Dr. Mangat, this particular portfolio. But on the left slide is a axial T1 weighted MR image with gadolinium-based contrast media. The way you can tell is you can see the transverse sigmoid sinuses look white. And that gives you the hint that this is with contrast media. And on the left slide, there's a little white arrow, and on both sides, they're like little white arrows pointing to little white dots. And that is the descending segment of the facial nerve through the styloid mastoid foramen. And on the right slide is a coronal T1 weighted image through the area of the sella. The way you can tell is, first of all, the two arrows there giving you the hint. But right above the arrows is a little crevice. That's the third ventricle. And then above that are the two frontal horns of the lateral ventricle. And you can see that the tip of the arrows are pointing to a little bowl, little concave or like a little saucer of a structure, and that is the roof of the pituitary, which should be horizontal or flat, parallel to the bottom of the image, just a straight line. But there's like a little banana, what looks like a banana, and that is the pituitary gland with a concave appearance. And so this is what Dr. Mangat is illustrating on these two MR pictures.
And Raymond is an excellent neuroradiologist. He's actually a professor at Georgetown University. He teaches the radiology residents, and he's just presented a number of papers at the SNR meeting. So Raymond, do you want to just comment about what you learned at the meeting about COVID?
Am I still audible? Can you hear me?
Very much so. Go ahead.
So first of all, what is very peculiar about this particular condition is that the virus, the inflammatory reaction, enters the calvarium through very specific pathways, one of which is the cribriform plate through the olfactory pathway. Another one is through the parotid gland, through the ears, through the 7th and 8th nerve pathway. And then what happens is that there is a reactive process causing increased vascularity around these structures, these particular structures, which causes the whiteness on the image or the increased signal on the post-contrast images. So it is very, so in this case that Dr. Mangat is illustrating, these structures do not normally enhance to the extent that you see in this particular image. And then also on the coronal image of the pituitary, there's increased CSF pulsation, causing this concavity appearance to the dome of the pituitary gland.
Beautiful, Raymond. That's great. So Raymond is a superb neuroradiologist. He publishes a number of stuff, and he teaches really well. I have a group of biomedical engineers, and he's taught them extremely well. So let me just go and continue and explain to you why I asked the questions. Okay, this is exactly what the MRI showed, exactly as Raymond said to you, what it showed. And essentially, it shows an empty cellar, which is important because that is a clue. And somebody talked about the caverna sinus. I think I know who that person is because he taught me. And the reason for that is that in the wall of the caverna sinus is the only place neuroanatomically where the 4th and 6th nerve are very close proximity. An empty cellar refers to fluid accumulation in the subarachnoid space adjacent to the caverna sinus. And that's exactly why she had double vision in certain gazes. The other important thing was the sound sensitivity. The sound sensitivity, as Raymond put it out very, very well, we're looking deep into the facial nerve as it goes through the internal auditory canal and burrows towards the stylomastoid foramen. And in the mastoid component, where we were showing the arrows, that's exactly where the nerve to the stapedius goes. And we see this in other conditions like neurological line. And the reason why it's important is that's your muffler. The stapedius is the muffler, so that if that nerve goes, everything sounds loud. So that was the reason why she couldn't track when she was watching TV. She couldn't see those Richard Lawyer's numbers. And that's the reason why the TV was too loud with an 8-year-old. So now we've got a diagnosis and we figured out what's going on. Next question is, how do you treat her? Any comments? Any ideas?
Yeah, I'd love to see what people think about this one. Very interesting. All right, what do you guys think? Let's see here. We have ivermectin and steroids are 2 suggestions so far.
Okay, let me make it a little more difficult. That's too easy. How do you treat them and why? And what things are you going to think about when you treat them?
Yeah, So someone's asking, someone's wondering if there's a relationship to the Moderna vaccine that the patient got.
We'll talk about that later. Peter will
Yeah.
tell you about it. Peter on the thing will tell you what we discovered by accident. Let's focus on the clinical anatomy and clinical treatment. We'll talk about all of that later on.
So we have osteopathic cranial treatment is, I think we have some osteopathic physicians on here, so suggesting that.
I don't know that one.
Yeah, anticoagulant. Someone's wondering if there's herpes virus involvement. Aspirin for anticoagulation.
Sure, aspirin you definitely do. She was negative for herpes. Okay. The way I thought it through was we needed to give a drug that crosses the blood-brain barrier. So the drug's got to have a molecular weight of less than 500. Anything above 500, we're going to have difficulties unless the blood-brain barrier is being impaired, and it's quite possible. I don't know the molecular weight of ivermectin. Somebody has to tell me that. What I chose to do in this case was I put her on hydroxychloroquine. Famotidine. Hydroxychloroquine's molecular weight is less than 500. Famotidine is less than that much. I also put her on Benadryl because that's less than 500. So I knew that would get across the blood-brain barrier. And the reason was I knew we had a mini cytokine storm, a mini bradykinin storm here, and treated her accordingly and watched her very carefully. And I think I may have given her antibiotics. I can't remember off the top of my head, but she was on antibiotics before she came to me. But the net result was she got better. Symptoms went away. And I think the repeat MRI showed no enhancement. But the name of the game is understanding that these enhancements is due to the proliferation of the virus within the cisterns. We have 15 cisterns around the brain, and they're all interconnected. I mean, Raymond really put it very well. It comes in different ways into the cisterns. Then through the cisterns, it goes different pathways. If you think about it, the olfactory nerve sits right at the top of the nose. It's the shortest pathway to the forebrain. And it goes into that cistern around that. And that's connected to the other cisterns which are adjacent to the cavernous sinus. And that's why we got pressure on that area, and that's why she got double vision. Now, if you think about it anatomically, when the pressure is elevated, it will go to the point of least resistance. Go back to your anatomy days. Your internal auditory canal is a pathway for that fluid, which is in the nervous system, in the subarachnoid space, to push out. And it will go through the least resistance into that 7th and 8th nerve. And that's why the balance issues with that, because it's inflamed. So whoever suggests that was right. So this is a very interesting condition. And we've got to be aware of that. And we've got to look at this a little more critically and not tell our patients go away. We've got to understand what it is and understand how to treat it. And that's the objective of showing this. And thankfully, she's a lot better and she's doing really, really well. And she can sit with a kid and watch her TV. And she's a great person. And, she's done very well. Okay, after that incident, we decided to look at long haulers. And we decided to do an analysis on long haulers. And we have about 5 long haulers who I'm actively treating. And they still didn't have a similar taste. So we reviewed the MRIs. And we found some very interesting findings. And this is essentially, let me go back to that slide. The key thing that came out was that the enhancement of the 7th nerve in the mastoid component, that came out in all of them. We also noticed that they had mastoid effusion, some of them. And in our review, as we published this at the CMDA, we realized Hopkins had done an autopsy study, and they had done 3 postmortems on COVID-19 patients. They all had mastoid effusions. So, you've got to be on this. This is something important. And we've shown it in living patients, how it transcended down there. And thankfully, there are a few others who we've seen that and we treated and they got better. But you can't sit on this one because we're going to land up in all sorts of problems. And this is the reason for the long haulers complaints. They're talking about brain fog. They're talking about increased sound sensitivity. They're talking about visual disturbances. And unless you know about that, you're not going to be able to make a diagnosis. And this is the evidence we have. We presented recently at the CMDA meeting, and also, Hopkins presented it just before us in the appropriate journal. This sort of say thank you to my staff. As they say, you don't have to be crazy to work here. We can train you. That's me. Now, this is something interesting. I'll just go very quickly over this. So what we did is we reviewed our patients and submitted the data to the FDA because we were using FDA-approved drugs. We didn't need their approval, but we wanted that stamp so that wouldn't cost us patients out-of-pocket expense. So we had 26 patients with lab-confirmed positive COVID-19, and some of them had monoclonal antibodies, those who qualified. The others received the multi-drug treatment that I alluded to. And we did a plot analysis. And basically, a plot analysis is looking at how the symptoms correlated over time. And we have a great statistician who did it for us out of Georgetown. And basically, he drew a very interesting graph. And essentially, the more negative the correlation, the better they were getting better faster. And it's very interesting. We used bamlanivimab at that time, with just bamlanivimab, a monoclonal antibody, and that had a positive correlation, not a negative. But all the other stuffs we used, Kaletra, Befespi, Alvesco, Imfamontidine, had a negative correlation. In other words, they were getting better quicker. The guy at the FDA got a little cranky at me, so he got an appropriate response. And I just sent his data back to their senator so he can investigate why they don't know anything, but that's a different issue. So conclusions, early treatment with repurposed drugs do work. This is what I use, and that's why I used it. I'm sure ivermectin will work, but you just got to pin it out to a mechanism action so that people on the other side cannot argue. That's my only take-home point. But this is the reason why I use the drugs and why I work on my patients. And these are just the clinical polls. 128 slide scanner is great. If you can get access to it, use it. Make sure you have a good radiologist. We talked about the risk of bamlanivimab, and you got to watch out for 2 to 6 days afterwards, and the value of just nasopharyngeal rinses. As I said, anticipate complications, anticipate atypical infections, and just be on the ball for your patients and do the best. I think that's it. I'll answer any questions.
Thank you so very much, Dr. Mangat. Really, really fascinating presentation. And thanks to all the interactive participation from everybody in the audience there. Okay, so we'll open up to Q&A here. And if you'd like to ask your question verbally, go ahead and raise your hand. Click your raise your hand button. So raise your virtual hand, or go ahead and type it in the Q&A box. We got one in the Q&A box here already, and how about we start with that? So this doctor is asking, how would you differentiate viral from fungal pneumonia clinically?
The answer is difficult. I mean, you got to just go with, it's difficult, to put it bluntly. It depends where you live. You're more likely to get fungal pneumonias in southern climates, Florida, less likely in the north. You can do viral titers. I've done viral titers, and the most common virus I'm seeing is Coxsackie. I mean, I've seen so much Coxsackie, it's unbelievable. I'm sure you can do fungal titers too. You got to figure out what fungus you're looking at. So it depends on where you are.
All right. Thank you. So a couple people are asking about treatments for long haulers. They'd love to hear your suggestions about treatment for long hauler syndrome.
That is so new. I don't know. What I started doing is sitting and talking to them, looking clinically, and imaging and finding out where the problem is. Then accordingly, I mean, there's a very interesting case, and we'll quote, and we're still confused what to do. I have a long hauler who essentially complained about ankle pain and everything else. And she also knew Lyme, so I thought she had Lyme arthritis. She insisted, so we made a fractured it. So we did x-rays on the ankle. Nothing came up. So she said, Dr. Mangat, I'm still hurting, could be a stress fracture. So we did a MRI, a 3 Tesla MRI with my favorite radiologist, Dr. Uppal. And lo and behold, we saw infarction of the talus, the dome of the talus on the lateral side. As Raymond and I were discussing this is crazy. That's full of blood. What's going on? And so when you started digging down further, I started looking at D dimers. The D dimers got elevated. So and that's why she was in intense pain. And immediately I put an Eliquis, sent her to my favorite academic orthopedist, James Gilbert. And James just looked at it and said, fascinating. He said, I'm going to put some stem cells in. In the meantime, I would figure out how to treat her. So what I did was I put her on Kaletra, I put her on hydroxychloroquine, I put her on a few other things, famotidine, I put her on the, also I put her on Benadryl. It began to come down, the pain got less. We're not home yet, but she's a lot better than she was previously. And that tells you this is just a very bizarre thing. And her D dimers came down, thankfully. The D dimer was a clue because she had marginally elevated D dimers. And after initiating treatment, and she got clinically better, the D dimers came better. There's another case, and I'm sure she won't mind me talking about her, of a post vaccination. She couldn't stand the dog next door barking and howling because of she got the same thing as the patient I presented. And we treated her, and she just wasn't getting better. And so I couldn't get an MRI for various insurance reasons. So eventually I got her to press down on her mastoids. They were tender. She had mastoiditis. Obviously, if you think about it, where we talk about immunosuppression. So I put her on clindamycin. So in combination with the treatment, which I just quoted, plus the clindamycin, she's clinically better. This is just too new. There's a lot of more information. We just got to pool our resources together, ideas together, to see who's got the best idea to go forward. I may be totally wrong, but the whole point is, unless we talk about it, unless we talk to each other, we're not going to learn. And that's critical in this.
Thank you. Thank you. All right. So let's see. We have a participant with a hand raised, so we'll see if we can bring him on. Dr. Blumrich, Richard Blumrich. I apologize if I'm pronouncing your name wrong. Let's see. I'm going to bring you on here. Dr. Blumrich, please go ahead. Welcome.
Okay. Oh, I didn't have an acute question now. I don't know if I hit a button by accident.
Okay. Yeah, we just your virtual hand was raised, but all right.
Oh,
no worries.
sorry.
No worries. Thanks for being with us.
Oh, I'll make one comment though, since I'm on. And that is with pregnant women, when we get to monoclonal antibodies, I'll put in my 2 cents, rather than giving one that's directed to the interleukin 6, I prefer the one that's directly against the spike proteins, which would be the Regeneron Cove. Now, in a fetus has really no immune system for most of its pregnancy. But when it does start, it starts with just making interleukin 6 and interleukin 1. And its only goal is basically to signal mom that, hey, there's something going on in here. So to give monoclonal antibodies, which are IgG antibodies, which are actively transported into the fetal compartment, I wouldn't want to mess with the kid's rudimentary immune system by attacking its interleukin 1 and 6s. And for what it's worth, I would go for the one with the anti-spike protein, because there shouldn't be any spike proteins in the fetal compartment. And if they're there, they won't be any different than any other maternal antibodies that get crossed into the placenta.
Thank you. Thank you for sharing that information. Appreciate it. Any comments, Dr. Mangat, that you'd like to share in response?
I think that's great. I mean, I'm not an authority in this. I'm going to profess to whatever you said, I agree with, because you want to target the monoclonal antibodies before, as early as possible. You don't want to get in that storm because we know it's a mess. We can get out of it, but it's going to be collateral damage. So I agree 100%. I'm just noticing there's a very interesting question from Mr. Bhagat Singh, I think it's in India. I have no experience in pediatrics symptoms, so I'm going to not answer. I just don't know enough. If anybody else wants to comment about pediatrics and COVID, they're welcome to, because that's a question I got asked about how would you treat kids with COVID.
Yeah, thank you. So there are a bunch of people here asking about if you'd be willing to give some feedback on the vaccines. Like, are you seeing any breakthrough infections with vaccinated patients, or any comments just that you'd be willing to share about the vaccines?
Peter, is Peter McCullough on there?
I don't think so. He had signed up, but I know he's pretty in demand in the media these days. So maybe he had an interview that.
Let me tell you what happened. This is like horrendous. What we noticed was that we started vaccinating people, and like my staff who did not do well, for a better word, we are seeing a spike in COVID cases post-vaccination. And my partner saw the same spike as well, and she noticed it first. Actually, she told me about it. I started looking, as I said, I called Peter McCullough. I said, Peter, look, Harminder's noticing this. I'm noticing this. Are you seeing anything in Texas? And Peter goes to me, yeah, I'm seeing the same thing too. We don't understand this. What we discovered after, that Peter emails me 2 hours later, and he sends me the data that Pfizer sent to the FDA. It's very interesting data. The data showed that on the cohort with which was blind, which had a placebo, there were 289 cases of COVID. On the cohort with the vaccination, there were 409 cases of COVID. That data tells us something. Additionally, we have people who do various things, and we talk, and they're noticing increased prevalence of thrombosis after the vaccination. I'm hearing all sorts of issues. The trouble is, I don't know what the reporting system, because the system, all these vaccines are not FDA approved. They're emergency use authorization approval. And that means we don't get the black box warnings. What's our system to solve this? What's our system to make people aware of it? I mean, each time I talk to somebody about the vaccination, I'm very upfront. I said, look, the vaccines are all EUA. They have risk. And I talk about the risk of the neurological complications on the Moderna and the Pfizer, and the thrombosis with the Johnson & Johnson and the AstraZeneca. And and discuss it through with them depending on their viewpoint. And some people are in a dilemma. They're being made to do vaccinations they don't want. I'm not saying that you shouldn't. I think we should vaccinate. But how do we guarantee and minimize these complications? And what shortcuts were taken? We need to know the full facts, which are not coming out. I'm not just here. I mean, I'm seeing the same thing in India, and Indian patients. I'm seeing horrendous complications. I mean, that patient I presented to you was somebody who had a vaccination. He still got COVID. I'm seeing that. So the question I'm really wondering is what's going to happen with that Indian virus lands here. It's already here. I mean, the Virginia State Department had to close down a Hindu temple in Virginia because the priest came back with the Indian variant. So I would keep our guard up until we know how to solve it. The saving grace is that we do have a new monoclonal antibody, which is being theorized and shown effective in vitro to be effective against that variant, and that's a GSK variant. So we should be treating early to prevent progression. But if we don't treat early, we're going to land up all these complications, which I'm seeing. And I'm sure the other people are seeing, but if you don't think about it, you're going to miss it. I mean, who would have thought? I mean, I never in my medical school career, my professional life, has seen infarction of the dome of the talus. I'm not sure anybody else has seen it. Even my orthopedist hasn't seen it. So what do we do?
All right, thank you. All right, let's see. We're a bit over time here, but we have a few more questions. Dr. Mangat, could you stay with us for just a little bit longer here?
Sure, go ahead.
Yeah, okay. Dr. Izaju, I see you have your hand raised. Please go ahead, Dr. Izaju. You may need to unmute your mic there, Dr. Izaju. All right, well, we'll wait for him, and if he comes on, great. So there's just a couple more questions in the chat here. Yeah, this is something I've wondered about. There are these people who've been vaccinated who are now testing positive for COVID. Are they getting COVID, or is it some complication from the spike proteins that are being made by the vaccine? Yeah, that's a very interesting question.
I can't
Okay,
answer.
can you hear me now?
Oh yeah, Dr. Izaju, welcome. Yes, we can. Please go ahead. Now we can't hear you. We heard you there briefly. Okay. All right. Well, maybe you could type your question in the chat room. I think we need to wrap up here. We're over time. It's pretty late for everybody on the East Coast. But Dr. Vliet, I just wanted to bring you back on to see if you had any final comments. And Dr. Mangat, do you have anything you'd like to wrap up to say in conclusion?
It was an honor to be on this. I think the take-home message, you've got to work together. That's so much ahead of us. You've got to work together, be sincere to our patients, and do the best for them. That's the most important thing.
Yeah. Thank you. Thank you so much for taking the time to be with us and for sharing your expertise and the fascinating case studies with us. Thank you. So Dr. Vliet, hi, welcome back. Any concluding remarks from your standpoint?
Well, I just owe a great deal of gratitude to Dr. Mangat for his outstanding program. And I think it was particularly helpful that you had such helpful diagrams on the slides to look at the different phases of illness. And just an observation, one of the things that I've been very struck by with this virus is that it is quite unpredictable. There are patients of mine that I've treated that I did not think had a lot of comorbidities, that should not have had as difficult a picture as they did. And I was treating them quite early, because most everyone I've treated has been within the first 4 or 5 days of symptoms. So we're getting them early. But I've really been struck by how unpredictable it can be and how quickly we need to ramp up. And I liked what you said about look at the patient and look at what's happening, and don't just follow a rigid algorithm, because I've really had to ramp up and speed up the pace of adding the different steps in Dr. McCullough's algorithm, for example, and much more aggressively than I would have thought for some of the patients. So I would just encourage everyone to realize it can go quickly from mild to quite severe, and be prepared with all of the things that Dr. Mangat has talked about. And the other thing I would mention, home oxygen concentrators are available through Home Health. And I've been very quick to order those if there's any question that the patients are getting in a little more respiratory compromise. I do not want them having the stress of oxygen concentrations running around 90 to 92. I want them to be able to have support for the lungs and the heart and the brain. So I've actually been ordering oxygen concentrators earlier rather than later. And it's amazing how quickly that can benefit them and help reduce the coughing and some of the fatigue and some of the vague side effects. So I think there may be a little more oxygen deficit than perhaps we realize, and that may be the massive inflammatory response that this virus triggers.
Thank you, Dr. Vliet. Thank you for sharing those comments. And I look forward to learning more about your new efforts with COVID early treatment as well. And we're running a little short on time tonight. Do you want to say a few quick words as a teaser about what you're up to?
Well, let me just say that in light of all of the censorship, all of the health system blockades, difficulty getting medicines in hospitals, I just felt that we needed to do outreach through a different venue. And I proposed with Dr. McCullough and some of the people that I've been working with in his team that we really needed to do early treatment centers in an integrated way, reaching out through churches and synagogues and faith-based outreach in the US. So I ramped up the foundation that my husband and I started in 2007 that was prevented by the economic collapse of 2008. And I kept it filed and active, but inactive all these years. And finally, 14 years later, I see a need for it. So 501c3 Foundation, Truth for Health. And the first initiative is Medicine and Ministry United. The second initiative is Catholics for Preservation of Life. And we are working with, I have a board of directors and medical advisory team, pastoral advisory team, and we're looking to move this out with telemedicine services in the churches and faith settings where we have freedom to work directly with the patients without all of the bureaucratic interference. So that's it in a nutshell.
Thank you so much for working on that, Dr. Vlady. And we look forward to learning more as that progresses and sharing information about that as it progresses. Thanks for doing that. And I wanted to, there's a number of comments of thanks to Dr. Mangat in the chat room for the wonderful presentation. This was very valuable. Thank you, Dr. Mangat, again for being with us. I just have a few quick closing slides I need to share just about the CME, and I'll do that very quickly here. Bear with me one second as I share my screen. Let's see. Okay, so I'm going to send you a link here shortly, and this is the screen you'll see. You'll have to enter the 6-digit code in the little white box that you see there. 73CION is the code. That'll be in the email. You don't have to write it down or remember it now. But then you'll click the next button, and then you'll see a page like this. And it may ask you for your phone number and email first, but you will then get to this page, and the thing to click is first the link next to the red arrow, complete course evaluation. There's a very short survey there for you to fill out. And after you do that, then you can click on the link next to this blue arrow, which will get you your certificate. And let's see here. So yeah, it'll ask you if you want to claim the maximum number of hours available. If you were here the whole time, you click yes. If not, click no and enter the amount of time you're on. Then you'll get your certificate. It looks like this. And at the top, the red arrow points to the export to PDF and print buttons, which may come in handy for you. And also you will get a link eventually if you haven't already used EEDS, EEDS, the system that we're using here. You'll get a link to confirm your account, which will then let you go back later and download the certificate again if you lose it or something along those lines, or just need it again for some reason. And all right, that's it. That's all I have to share. Let me stop my screen sharing here and just say again, thanks to everybody. And look forward to seeing you again next time. We'll have an announcement here shortly about our next webinar, which will be coming up soon. And again, also, as I mentioned at the beginning, save the dates for our annual meeting, October 1st and 2nd. Actually, there'll be a welcome reception the day before, September 30th. But so with that, we'll go ahead and wrap up, call it a night. And until next time, from all of us at AAPS, good night and thank you again. Goodbye.